to another episode of board review using AI tools. We're continuing to use Gamma AI for our presentation, and we are using ChatGPT, Manus AI, Perplexity, and I'm starting to use Notebook LM to create and compile these questions to make sure we don't miss any educational objectives that are very high yield on the internal medicine board exam. Right now, I've been on my third week of my night shifts straight, and it's about 1 hour and 20 minutes from my shift. In fact, now it's about an hour from my shift, and I'm recording this video for you guys. I hope you guys are enjoying it. If you do, please drop a like, comment, subscribe. If you like this format, definitely let me know in the comments what's working for you and not. So the first question, we have a 58-year-old woman with hypothyroidism. She presents with new onset palpitations, weight loss, and anxiety. She's been on the same dose of levothyroxine for 13 years. 4 months ago, she stopped taking her estradiol, which was prescribed for her menopausal symptoms. The vital signs reveal tachycardia, hypertension. Labs show suppressed TSH and an elevated free T4, which of the following is the best explanation for her current symptoms. So go ahead and pause the video right here, pick your answer, and then we're going to go through the question together. Okay, so this is a very, very important educational objectives on the board, and this is about effect of hormone on thyroid binding globulin. So this patient, basically the only thing that changed in her medication history was that she stopped taking the estrogen and she presented with thyrotoxicosis. So you might think, what happened? Well, TBG function is to bind majority of the circulating T4. Estrogen increases the thyroid binding globulin, which basically that will reduce the free T4. So if you take off the estrogen rapidly and don't change the dose of the thyroid hormone that they're taking, with the amount of decrease in thyroid binding globulin, there will be increased free T4, and the patient can present this way. It's a very important, high yield topic. So remember that the differentials and things to consider here was that decreased TBG concentration, increased absorption, or a medication interaction. There was no other so for example, for medications, there was no rifampin use mentioned, no evidence of renal disease or adherence issues. In terms of absorption, we didn't hear anything about a calcium supplement or a cholestyramine that would affect the absorption. The decreased TBG concentration was the most plausible here. The estrogen discontinuation lowers the TBG, and that same level dose of levothyroxine results in a higher free T4 amount, leading to thyrotoxic symptoms. And always, when you are tackling thyroid questions or on clinical decision making in real life, assess that TSH and free T4 levels, review the medication changes, and think about the how they could affect the thyroid binding globulin as one of the most important things to know about, and then adjusted those accordingly. And again, this kind of pattern that you see here was very the boards also will give you some distractors, but somewhere in there it says the patient was on estrogen therapy and it was stopped, and then you just have to pick that up and recognize that question. So the treatment guidelines, the American guidelines, monitor the thyroid function 6 to 8 weeks after starting or stopping this estrogen. So that's the guidelines, American guidelines, and they want you to make sure that you repeat your thyroid studies after 6 to 8 weeks after starting or stopping estrogen. Adjust the syntheroid dose and target that TSH to be within normal range, and then reassess the TSH and free T4, especially if symptoms suggest thyrotoxicosis. So this question, the correct answer was decreased thyroid binding globulin concentration, which explains the elevated free T4 and a suppressed TSH. All right, question number 2. Again, another high yield question. So 66-year-old man presents with fatigue, polyuria, confusion, has had a 40 years smoking history, and has lost about 15 pounds over the past 3 months. Again, the boards will not tell you that. They may just tell you about the fatigue and polyuria and confusion. Calcium of 14.8, PTH low, and then PTH-RP is elevated. Chest X-ray reveals a right hilar mass. What is the most likely mechanism of the patient's hypercalcemia? So just a pure question about how does this basically how is this causing? What is the cause of her hypercalcemia? Now, again, these questions are trying to teach basically a one single point here, but also we'll go over the differentials. But the most important thing here is that PTHRP secretion, right? So patient presents with a calcium of 14.8. I'll tell you, if a patient is presenting with a calcium greater than 13, and that's the magic number that you need to know about, that is very important to consider malignancy as one of the causes. And in this case, we have, the PTHRP secretion, which is 80% of malignancy cases. They mimic PTH, basically increase bone resorption and renal calcium absorption. Osteolysis is common in multiple myeloma and breast cancer with bone mets. And then vitamin D overproduction, remember those lymphoma cases or granulomatous disorders can present with those mechanisms of hypercalcemia. The differential diagnosis is, as we talked about, bone osteolysis. You see those in breast cancer, myeloma with bone mets. It's not very consistent with the lung cancer in this case. Vitamin D overproduction, again, we talked about lymphoma. PTHRP is very classic for squamous cell lung cancer and would explain that elevated calcium level. So when you have a hypercalcemic patient, you always measure the PTH. If it's elevated, you have a primary hyperparathyroidism. If PTH is low, then measure the PTHRP, vitamin D, SPEP, and UPEP. And if it's elevated, consider PTHRP-mediated hypercalcemia. And this patient had the weight loss, the smoking, high calcium, low PTH, and high PTHRP. And to make it even better, a hilar mass. Squamous cell carcinoma, remember, it presents more central. And that was going to be the correct answer. And the initial workups, again, calcium, PTH, PTRP, 25 OHD, and the 125. If you have a patient with severe hypercalcemia, you want to start with fluids. You can try calcitonin for fast acting, and then for a longer day effect, we add bisphosphonates and denosumab if they're still refractory, and we need to treat the underlying cause of that malignancy to basically prevent this hypercalcemia to cause more complications. All right, next question. So this is the third question. We have a 72-year-old woman. She presents with AFib and she's on amiodarone. She has palpitation, heat intolerance, weight loss. As you can see, heart rate is 108, temperature is 99.5, and the BP is 140 or 82. TSH is decreased. Free T4 and T3 are elevated. The radioactive iodine uptake is undetectable, and the thyroid ultrasound shows decreased vascularity. So which of the following is the best next step in the management of this patient, basically? Go ahead and pause the video right here, pick your answer, and go through the options together. Okay, so this is another important board question. Amiodarone-induced thyrotoxicosis and the way it does it. So this was a patient who is on amiodarone. They present with that elevated T3, T4 and undetectable RIO and decreased vascularity. So that's very important, right? So the composition, right? Amiodarone contains 37% of iodine by weight. Very important, leading to multiple thyroid effects. It can inhibit that 5-deiodinase. It can cause hypothyroidism, and it can even trigger thyrotoxicosis. So the amiodarone iodine-induced type AIT type 1 is that iodine-induced excess hormone synthesis. That means often someone has maybe a nodular goiter, and once they get the amiodarone, they have increased RAO uptake and increased vascularity. But type 2 is a type of a destructive thyroiditis with release of the preformed hormones. So the patient will present with the suppressed TSH, high CT4, undetectable RAO, and decreased vascularity on ultrasound. So very important to know and to be able to distinguish between these. So radioactive iodine, it's not an effective in AIT type 2. the gland is not actively taking up iodine. Methimazole is for type 1 because there's active hormone synthesis and not type 2. Glucocorticoids is the correct answer here because it blunts that inflammatory destruction in that AIT type 2. And other options were like beta blockers can help symptoms but are not definitive treatment. And a lot of times these patients, you cannot really stop amiodarone. So you need to consider that. So the management of AIT, check your thyroid levels, right? TSH and see the T3 and T4. Get a RAU and a thyroid Doppler, which is radioactive iodine uptake and thyroid Doppler. Determine the type based on that and the vascularity of the gland. If it's type 1, you have high vascularity and it's not a destructive situation. You can just, it's an uptake problem. Basically, the iodine uptake increase. You can treat it with methimazole. Of course, consider patient what age and pregnancy if they are. Type 2, it's going to be the destructive one. You can try glucocorticoids, and sometimes it could be mixed. So always, in this case, type 2 patient, high dose glucocorticoids, classic type 2 and destructive thyroiditis from that amiodarone, and should be treated with the guideline base is 40 to 60 milligrams a day of prednisone and we need to taper it over the 2 to 3 months. Okay, so very important to know that in practice. And guys, this is the last question and explanation here. I hope you guys enjoyed this presentation. As you can see, the presentations are very clean, to the point, the educational objective expanded, and these are very, very high yield, guys. I hope you guys are enjoying these episodes. If you do, please drop a like, comment, subscribe. Let me know what you think about this, and we'll definitely see you on the next one.